So tonight we are going over cardiovascular emergencies. This is going to be very similar to how we did the respiratory emergencies chapter. So we're going to talk about the different diseases. Well, first we're going to talk about the anatomy. We're going to go back over that, especially for the heart. It's very important because the heart has two main functions and it has its own two different sets of anatomy, right? You got the electrical side and the hydraulic side. So we're going to talk about all that. Then we're going to talk about where things go wrong. And then we're going to talk about what we can do to fix them. There's a lot of stuff that we can do that um, is aggressive and good for your patient. That I say aggressive because I mean I don't want you to just sit there and get a set of vitals and then look at the paramedic like he's supposed to do everything. That's not necessarily how it works, and your paramedics will love you if you can actually take some initiative and get some things done so that they don't have to do everything. Because there's a lot of stuff that's within the EMT basic scope that you can do. Now, granted, yes, there's limits. There's going to be points where you have to kind of step back and say, all right, everything needs a gold patch from here, but that's just part of it. Um, but even the paramedics are taught to do basic life support first. So if you were to just step back and look at them, they're going to do your job first, and then they're going to do the advanced stuff. So I don't want you guys to go out into the field and have that mindset. So I want you to I want you to be able to basically hold your own. All right, so that the paramedic can be taking the time to set his IV and get his meds ready and stuff like that while you're doing a lot of the BLS stuff. And there's a lot of stuff that you can do kind of at an ALS level, just not with the patient. So like as you learn, you'll be able to figure out what meds the paramedic needs. So even though you can't push them, you can be getting them set up. All right. There's the way that the meds are stored. They're usually kept in a box. They're in a vial that has to be connected to the syringe to push. So the paramedic has to set the IV. You as an EMT can be getting his meds, his ACLS drugs set up while he's setting the IV, as opposed to just watching them set the IV and then watching him do the drugs, that kind of thing. So we're going to go over. This is a chapter that I tend to geek out on, so I'm going to try not to make y'all's eyes glaze over. If I do lose people, let me know. I don't think I'm going to lose you in complexity. That's not what I mean. But like if I'm just going off the rails on something and it's like, all right, you know what, we're getting out of paramedic level two. So um, just I would say throw something at me, but say something. All right. Cardiovascular disease accounts for about one of every three deaths. You guys in the fire service, this was our leading cause of death for years. Cancer has taken it over, but this is a major, major thing. All right. EMS can help reduce deaths by providing the following services. Some of the things that we do, besides actual, let me hit you with some nitro, is let's be proactive. Try to encourage a healthy lifestyle. That's healthy eating. No, you don't have to eat salads forever, but maybe lay off the bacon a little bit. CPR training. That was actually what we started off doing with ARES was CPR. I came back from deployment and I was like, well, I'm a CPR instructor. I'll start there. And that's what we did. And then we just kind of branched out. And now we have the EMT program, the advanced EMT, but we still do CPR. We still try to get as many people certified in CPR as we can. Something you can do in your fields is even just teach compressions. You don't have to teach mouth to mouth. You don't have to teach them how to use a BVM because let's face it, the guy that works at Walmart is not going to be carrying one of those things around. But they have two hands and some core strength, they can do some compressions, and that alone might save somebody's life while you're waiting for EMS to arrive. Increased use of evolving technology in dispatching cardiac arrest response has really helped a lot of things. Some dispatchers are trained in CPR now, so they can lead you through it over the phone. Not you, but the the Walmart employee, that kind of thing. Public access to defib devices, so your AEDs, you're seeing them pop up more and more. We're actually working on a program to get more of those out. As soon as we get that off the ground, I'll be letting y'all know, and then hopefully through y'all, we can get people more public access to AEDs. They're big. And we'll say this in the chapter. The majority of your cardiac issues begin with an electrical problem. So very few people go straight from perfectly functioning heart to just dead muscle. That is a thing, yes, but most of the time it winds up being that the issue started with a rhythm that could have been shocked back to normal. Um, so early AED intervention, easier, but more public access to it. That's huge. Um, but again, if somebody's heart goes bad, we really don't. You're not gonna cure somebody of heart disease in the field. What we do is we stabilize them and we get them to the hospital. So something else that has helped is a increase in cardiac specialty centers. There's more cath labs being stood up. There's more ERs being stood up. That means less travel time for an ambulance, which is fantastic as long as the receiving facility can actually do something. Um, and if they can't, I mean, let's be real. If you live in an area that has a hospital that is horrible at their job, all right, because not all are created equals, and it can be a funding issue, it can be a training issue. We all talk crap, right? Everybody talks crap. We talk crap about dispatch, we talk crap about hospitals, and so on and so on. It's just part of it. But don't complain just to complain. If you see something wrong, try to fix it. Try to help point that stuff out. Be like, hey, I'm on the ambulance and I come into this ER and I see this all the time. Maybe approach them tactfully about increasing their training. If it looks like the problem is just people aren't really familiar with the crash cart or something like that, that is something you can do. That can translate in directly into saved lives for people that you never even put your hands on because you helped get that hospital or that dispatch center or whatever. You helped improve their response capability because now they're not going to be staring at a drawer full of atropine trying to find the epi because they're looking in the wrong drawer or something like that. Um, Anyway, I won't get too much on the soapbox with that, but these are some things that we can really help with. We are in this as a team effort. The paramedic is not the end all. The EMT is not the end all. The patient has to get to the hospital, hopefully with a pulse. So, um, we do it to try to help the patients out. Just because you hand them off at the hospital doesn't mean that that's the end of it per se. When you can really help out in other areas. So, a quick anatomy review. The heart's job is to pump blood to supply oxygen-enriched red blood cells to the tissues of the body. That includes itself. Okay, so we have who can name the artery that feeds the heart? Just in general, it breaks down from there, but there's a general term for those arteries or a general name. Not the veins. Well, the veins. Okay, I see where you're going with that. So the veins feed the blood to the heart from the body for the heart to beat it out, but the heart has its own blood supply. You're getting warmer. It's not the aorta. Coronary. There you go. Sharon got it. Coronary arteries feed the heart itself. All right. They branch off the base of the aorta. So every time the left ventricle beats and shoves blood through the aorta out to the body, a little bit of it goes into the coronary arteries, and they're very, very small. Remember, we talked about CPR and why we want to do compressions the way that we do and not interrupt them too soon. The valve that allows blood into the coronary arteries from the aorta is a very strong valve. It has to be because those coronary arteries are very small. They start feeding the heart immediately at the base of the aorta. And that aorta, as you've seen in any picture of a heart, you see that massive red vein or red artery that comes across the top of the heart. That's the aorta. So the highest blood pressure in the body is going to be there, going immediately to these tiny little arteries that feed the heart. Um, that's why our blood pressure is important, right? Because if it dips too low, if we don't have good pressure, blood can't get into the coronary arteries, and the heart was not going to get the oxygen that it needs because it's a muscle. It's got to have its own blood supply. We divide the heart into left and right sides, and remember, if you're looking at the patient, anytime you determine like if it's a left-sided issue or a right-sided issue, or if you're trying to um, explain something, remember that it's the patient's left and right. So if you're looking at it from your point of view, the left side of the heart is on the right side of you, right? It's reversed. Blood leaves each of the four chambers of the heart through one-way valves. We talked about those. The big ones I want you to know are going to be the tricuspid and the bicuspid. Um, which one is on the right side of the heart? See if we can do this without a picture.
Tricuspid.
Good. Tricuspid's on the right side. That's if you're looking at a diagram of the heart, remember that's the left-hand side. So, here, I'll tell you what, well, give me a second. I'm gonna draw y'all a picture and try to explain that a little bit, unless we have a picture. Oh, never mind. There we go. We'll use this. All right. So if you look at this heart, look down at the ventricles toward the bottom. You got the right ventricle. It says tricuspid valve, and it's that big white area. And then you have the mitral valve on the right-hand side, or your right-hand side is the left side of the heart. That's a bicuspid valve. There's only two cusps that make it up. They call it mitral or bicuspid. It's the same valve. It's potato. If you look at this, the flow of the heart generally goes from your left to your right. All right, the flow of the blood is going to come into the right atrium, which is on the left side of this picture, and it's going to flow as it goes until it leaves out the left side, which is on the right side of this picture. So if you can remember that makes it a lot easier for you to remember the flow of blood through the heart. All right, your vena caves dump into your right atrium. Atrium is called that because it's just like the atria to a house. That's like an entrance collection point. It goes from the right atrium to the right ventricle, and it pushes through the pulmonary artery to the lungs. At this point, the blood is still deoxygenated. So this is one of those exceptions to the rule that arteries carry oxygenated blood. This artery is actually still carrying unoxygenated blood, and it's at a low pressure because it only has to go to the lungs. Once it reaches the lungs, it's going to have a gas exchange. You're going to drop off the carbon dioxide to be exhaled, and you're going to pick up oxygen that was just recently inhaled. Then it's going to come back to the heart on the left-hand side through the pulmonary vein. So again, keeping with that exception to the rule, this is the only vein in the body that carries oxygenated blood. All right, because it's returning to the heart. All arteries go away from the heart. All veins come back to it, whether or not it's oxygenated blood or deoxygenated blood. The pulmonary vein is going to dump into the left atrium, which again is a collection point. And now, like I said, for the flow of blood, if you're looking at this picture, now we're on the right side of the picture, the left side of the heart. It will go through the bicuspid valve from the left atrium to the left ventricle. And that's where, if you look at this picture, the meaty side of this heart, that brown area that basically outlines the ventricles, that's the muscle. That the thicker side is on the left-hand side because that's the side that's got to do all the pushing. So it shoves out through the aorta and to the rest of the body and the head. And then it just goes through and it repeats the process. Comes back through the vena caves, makes its route through the heart, across the lungs, comes back, shoots out over the aorta, goes to the body, comes in through the vena caves, and it just keeps on going. Under normal conditions, you will not find blood anywhere outside of this closed loop system. All right, there's some animals that have an open loop system, like worms, but that's not us. Everything is enclosed in your cardiovascular system. If the blood ain't there, if you find it anywhere else, that's a problem. All right. No matter what organ it's going through, like the lungs, the spleen, the liver, all that stuff, even though it's going through other organs, it's still traveling through the bloodstream in the arteries and veins. It doesn't just exist in like loose in the liver. All right, that's cars that have gone off road at that point, and that's not a good thing. All right, so we talked about that. This is showing the blood flow. All right, we just explained that, so we'll skip that. So let's move on to the electrical system. What we just talked about was the hydraulic system, right? That's fluid in motion. So now we're going to talk about the electrical system. This side of the heart determines how fast the heart beats. Everything about the electrical system, that's its sole purpose, is setting the pulse rate. All right, so the heart's electrical system controls the heart rate and coordinates the work of the atria and the ventricles. They have to beat in a certain order. If they, like, for example, if the AV node did not pause the electrical impulse between the SA node and the ventricles, because electricity goes so fast compared to the actual beat of your heart, the heart would essentially just squeeze both atria and ventricle at the same time and it wouldn't really do anything. You've got to give the blood time to get from the atria to the ventricles. So the heart, every piece, even the backups, like the AV node is the backup to the SA node. But even when the SA node is working, the AV node still has a purpose, and it's to pause that electrical impulse for a little bit. Um, so that's what that does. The heart generates its own electrical impulses starting at the sinus node, and the impulse passes from the atria to the ventricles. The heart will follow the fastest pacemaker. The SA node is the fastest. Its intrinsic rate is 60 to 100. That's what our normal pulse is. But the heart will take a pulse from itself if the SA node, if all the nodes fail. Like if the SA node fails, the AV node is going to pick it up. If the AV node fails, then the Purkinje fibers and the heart tissue itself is going to pick it up. Any individual heart muscle cell can produce its own beat. So you have a ton of backups. But the problem is that the nerve cells of the, or the, I'm sorry, the cardiac cells of the heart, they don't beat anywhere near as fast as they're supposed to, and it's completely disorganized because any individual cell will only know what's happening right next to it. And if you're a cell, I'm gonna mute y'all. Give me a second. Okay. If you're an individual cardiac cell and you're just chilling there, you're not doing anything, you don't plan on starting the heartbeat anytime soon or anything like that, but the cell next to you does, you're gonna pass it. You're gonna be like, "Ooh, I just got shocked," and you send it on. So it's an automatic thing. If one cardiac cell fires, that will spread. It has to spread. It's not just there's the cardiac cell is not going to take it and then just let it go. Um, and that can sometimes cause issues because the heart may be following the SA node, beating away at 60 to 100 beats a minute, but then just a random heart cell fires off, and now you've got what is considered a premature beat, right? Um, we don't fix that in the field, but you might encounter it, and that's what's happening. So I want you guys to know about that. But essentially, all the system does is it keeps the heart beating. So the SA node beats at 60 to 100. Does anybody remember what the AV node beats at? I definitely won't be upset if nobody knows this one. That's a tough question, especially if
40 to 60.
40 to 60. Good. Okay. So if the SA node fails, if you're looking at a patient that you think is having a heart issue and you check their pulse and they're riding around at the 44 range or something like that, is that a red flag to you that something might be wrong with their electrical system? Could be. Yeah, it's not definitive. And a paramedic is going to want to put a 12 lead on them and watch. But I mean, as an EMT basics, that's a good assumption, and you can base your plan of action off of that. If their heart rate is even lower than that, same thing. And you're gonna and if that's happening, you're gonna see a lot of physiologic changes in your patient. They're gonna diaphoretic. Their pupils are going to constrict or change. You know, their vital signs are going to get out of whack all over the place. They might have that feeling of impending doom, if you've ever heard of that. The scariest thing a cardiac patient can tell you, or that I've ever heard at least, was I walked in the room, he looked at me and said, "Please don't let me die." Like, that's not the way you want to start the conversation, man. So, but that's the thing. When your heart is messing up, your brain knows it, and you'll see that your patient will exhibit real fear usually. Yeah, or I'm dying. I'll just flat out tell you, like, this is it. You know, anybody ever watch Sanford and Son? Okay, I don't remember if I wasn't sure if they still played old reruns of that show or not. But every time Fred Sanford would get in a fight with his son, or somebody would say something that he didn't like, he'd clutch his chest and like, "This is the big one. I'm coming home," and all that stuff. Yeah. um, that's in jest, obviously. But if a patient is really telling you something like that, take them at their word. It's a difference between saying my stomach hurts. If somebody's gonna fake, it's a big difference between saying my stomach hurts and saying I'm gonna die. Usually you can take that to the bank. Be ready for CPR, get the AED out. All right. But anyway, back on this. Automaticity allows spontaneous contraction without a stimulus from a nerve source. So basically what that's saying is like if the SA node doesn't fire, the AV node doesn't fire, any particular nerve source along the way, or even cardiac cell within itself can actually produce the shock. As long as an impulse comes from the SA node, the other myocardial cells will contract with when the impulse reaches them. If no impulse arrives, though, your cells can do it themselves. But it's kind of like a good analogy that I like is the shop foreman and the factory workers. The SA node knows everything that's supposed to happen, knows how fast it's supposed to happen. He's the main guy in charge, and he's got his job down. All right, that's the SA node. 60 beats to 100 beats a minute, and he's on it. As long as he's working, the heart is a well-oiled machine. But let's say he gets sick and he doesn't come into work. Well, he has an assistant that kind of knows what he's supposed to do. He's a pretty good backup, but he's definitely not the shop foreman. He's not the main guy. And so he's getting the job done. All right. But he's not trained for that level. He's not as fast. There's some things he misses. And production just kind of goes down a little bit, but it's still going. Oh, by the way, he's not very strong at his job and he tends to get tired and quit pretty easily. So, if he's in charge for too long, he's going to just quit because he's not getting paid what the shop foreman should get paid. So he's not going to do it for long. And then once he quits, then it's up to the workers themselves to get it done. And even though they can do it, they're not going to do it it's going to be pretty much like when the cat's away, the mice will play. They'll get the job done, kind of. They'll at least show up to work, but they're not going to be productive at all. And at that point, you might still have an actual pulse, but it's not going to be enough to sustain life. So that's where we don't want it to get to. And as the electrical system shuts down, each backup is slower than the last one. So checking somebody's pulse is a great way to know if this is where their problem is at. At least in the sense of, the SA node versus the AV node and all that. All right, so here's your layout of the heart from an electrical conduit system. That green bulb on the right side of the heart, left side of the picture, is the SA node. It stands for sinoatrial. All right, sinus meaning that it's coming from a sinus area. It's a normal, straight, solid rhythm that's not going to change unless it's supposed to. And atrial because it's located in the atria. So SA node. Those red lines coming off of it, that's your intranodal pathways. They go around both atria. All right, so it shows it here just over the right atria, but it really goes around the left as well. They converge again on the AV node, called that because it's the atrioventricular node. It sits right between the atria and the ventricles. So if you ever get confused on the names or the locations, that's why they're called what they're called. The AV node is the backup to the SA node. It beats at a slower rate, but it's also nicknamed the gatekeeper because every time the electrical impulse hits it, and I'm not going to go into the anatomy of the AV node for a basic class, but it has a function that it holds up that electrical impulse for about a half second, and then it releases it to continue on down. It goes to the bundle of His, which is basically a little section before it branches off. It runs down that, and now the bundle of His and the actual bundle branches are like a superhighway. All right, you went from a 55-mile-an-hour highway to the Autobahn. It goes very, very fast once it hits that section, and it shoots down. That doesn't actually create a pulse anywhere in that septum area. Once it gets down to the apex at the bottom of the heart, that's where the Purkinje fibers start, and that's where the pulse begins for the ventricles, so that you have a top-down and a bottom-up flow of your heart being able to beat. So that the reason it's two different beats is because that electrical impulse is held up at the AV node, and it's top down, bottom up. That's the flow of your heartbeat. There is a left and right side bundle branch block. We'll talk a little bit not block. We'll talk a little bit about when those things get blocked, but I'm not going to make y'all masters of that because that's more paramedic level stuff than it is EMT. but we'll talk about it so you're aware of what that means if you ever hear a patient tell you that they have a bundle branch block or something of that sort. The autonomic nervous system controls involuntary activities of the body. That includes your heartbeat. We really don't control our own heartbeat. You can control our breathing rate, which indirectly controls it, but I can't just sit here and think, hey, pick up the pace on my pulse and it do that. The autonomic nervous system has two parts, which usually balance each other. I call it a game of tug of war. You have your sympathetic nervous system, which is your fight or flight. That's what really kicks you into overdrive. And it will basically amp you up. It'll pick up your pulse. It'll raise your blood pressure, dilate your pupils so that you can get more light in, so you can see in the dark. Think of it like if you were fighting a predator. You're going to be on your toes. You're going to be ready to pounce. You want to see in dark places better. So your body's going to react in that way. That's your sympathetic nervous system. Your parasympathetic nervous system is the opposite of that. It brings you back to your baseline. Think of it like muscles. A muscle can't push, right? Muscles can only contract, they can only pull. That's why we have opposing muscle groups, like your biceps versus your triceps. One has to relax so that the other one can pull it back. That's what this is. It's a game of tug of war. Your body dumps adrenaline into the system. It kicks in your sympathetic nervous response. Your vitals jack up because we basically just put one side of that tug of war on steroids. When we no longer need it, your body dumps dopamine in the system and it brings it back down. So that's essentially how this works. And that's how we control it. That's how your body controls the pulse rate. The myocardium must have a continuous supply of oxygen and nutrients to pump the blood. If the heart does not get the oxygen it has or it needs, that there's a term for that. I want you guys to know it is called ischemia. All right. So if you've ever heard the word ischemic or something like that, that is basically saying that the heart itself is not getting the blood supply to give it the oxygen that it needs. Increased oxygen demand during periods of physical exertion is supplied by the dilation or the widening of the coronary arteries, right? So if your heart's working harder, it needs more oxygen, the coronary arteries will dilate. So your parasympathetic nervous system, actually, take that back. Your sympathetic nervous system is kicking in and it's causing those coronary arteries to dilate. Think of it like we're putting in more lanes in the highway so I can get more blood through. More blood means more oxygen, and the heart can actually handle its workload better. And the last thing that you see on this slide is your stroke volume. Stroke volume describes the volume of blood ejected with each ventricular contraction. So your stroke volume is if your heart can, I think we talked about CHF the other night. And this is where this kind of becomes an issue. If the heart gets constricted because there's fluid in the chest or popped lung or any of that stuff, the heart no longer has the room to beat as good as it wants to. All right. When the heart can't completely reset to refill with blood before the next beat, the stroke volume is going to decrease. And that basically means, from a layman's standpoint, it basically means that there's not as much blood being pushed to the body with each beat. So the heart's going to have to do something. It's going to have to pick up the pace and beat more. Problem is if the stroke volume is dropping because, say, you're losing blood and your heart picks up the pace, what do you think that's going to do? If you're actively bleeding, say you were in a car accident and you lost your foot, yeah, you're going to lose more. You're just going to lose more blood faster, and that's not what we want. The coronary arteries are blood vessels that supply blood to the heart muscle itself. Like I said, and they break down further from that, but as EMTs, I'm just going to have you guys know coronary artery in general. You have a right side and a left side, and then you have some descending areas and things as it goes down the length of the heart, but you don't have to know that per se at this level. And here's just some pictures of your coronary arteries on the anterior and posterior view. If you guys go on to be paramedics, you're going to have to master these coronary arteries. All right. You look at your 12 leads, you can kind of tell based on what I'm looking at this piece of paper, I can say that particular coronary artery has got the problem and so on and so on. Or somebody tells you that they had coronary artery disease and you look at your EKG, you can be like, yeah, I can see signs of an old injury, that kind of thing. So for those of you wanting to go on, do a little bit of research. It'll get you ahead of the game when you get to our paramedic program if you already know the coronary arteries and like which one feeds which part of the heart and that kind of thing. You'll need that for cardiology at paramedic level. All right, arteries supply oxygenated blood to different parts of the body, and veins bring it back. But now keep in mind, there is exceptions to that, right? So the pulmonary artery is backwards. The pulmonary artery is carrying unoxygenated blood. So what I want you guys to get used to, don't fall into that trap with this slide. Not all arteries carry oxygenated blood, but their general job is to provide oxygen. So you have your right and left carotid, which is in your neck. You have your right and left subclavian, your brachial artery, which is in, where's your brachial? We don't lose this artery in adults. We just don't check it because we can't really, our muscles the way we can.
It's in your arm.
In your arms, right between your bicep and your tricep. You have your radial and your ulnar. Those are the two arteries that run down toward your wrists. The radial is toward your thumb, and the ulnar is toward your pinky. That's where we cut the radial artery, the radial pulse from. Your right and left iliac runs down around your iliac crest. Your right and left femoral, we can feel that one. That one's a little bit of a pain to find, but once you find it, if you ever need to feel somebody's femoral artery, take a pin, and when you do finally find it, mark it so that you can get back to it easy. The femoral artery, you can feel it kind of in the groin, one on each side, and it's just because, especially if it's a guy with like leg muscles or whatever, or a heavy set person, finding that artery can be a real challenge. So I just say that. And then you have your anterior and posterior tibial and perineal arteries. So we're just basically working our way down. Arterioles and capillaries are smaller vessels that receive blood from the arteries. So basically it's going to go arteries, arterioles, capillaries. And then on the way back, it's going to be starting from the capillaries, going to the venules, then to the veins, then back to the heart, and then it just repeats the process. Your blood consists of several types of cells and fluid. The bulk of your blood is called plasma. That's what gives it its liquid, right? The liquid amount. Plasma is basically just the binding agent that keeps all the red blood cells together, or all the blood cells in general together. A good 90% or so of your blood volume is plasma. But then we have our actual workers that are in the blood too. You have your red blood cells, which carry oxygen, and they do that because they have hemoglobin in them. White blood cells, which fight infection. That's all you really need to know about that. You guys get into an anatomy class, you're going to go deeper into this, but for EMT, that's good. And then your platelets, which help clot blood. Now your platelets are basically just shriveled up blood cells, like red blood cells. There's no nucleus. They don't think. They don't do any decision making. They just exist, and they exist in a shape that allows them to hook onto things, so that if you have a bleed, as the blood is going out, the platelets that are in the blood are going to start to catch, and they're going to catch to the edge of the vein, then they're going to start to catch onto each other, and then they're eventually going to just kind of close that wound up. That's how we clot. That's how we build our scabs, all that stuff. So if you take a blood thinner, you're basically lessening the amount of platelets that are in the blood, which is great because now you're not going to build clots as much, but it also kind of sucks because if you get an injury and you're bleeding, it's going to be that much harder to stop the bleed. We give patients, to help stop their clotting, we also give patients aspirin. Is aspirin a blood thinner? Does it actually remove platelets or lessen the amount of platelets in the blood? No, it doesn't. That's a misconception. So how does it work then? I'll go and tell you the aspirin is considered a platelet deaggregator. That's what they call it. So what does that mean? Makes them clot less. Yeah, pretty much. So the way I describe it is it pretty much slicken. It's like putting oil in the system. It makes things slick. It makes it to where even though you've got all the same amount of platelets, they can't really grab hold of each other as easily. So that is great when you're not dealing with an active bleed. If you have a patient that has like AFib, which we'll talk about in a little bit, um, one of the problems with AFib, atrial fibrillation, is that they are at high risk of developing clots in their atria. And depending on which atria that builds that clot could either wind up going to the lungs, which is a major problem, or it could go to the head, which is also a major problem. So we give aspirin to help slicken things up so that the clots don't form as easy. All right, your blood pressure is the force of circulating blood against arterial walls. That is going to rise and fall based on your activity, based on your age, your diet, all kinds of things. And trauma and different things like shock will mess with it too. I could give you a class just on blood pressure. There's so much stuff that you can learn from the numbers that you get from this that isn't really out of scope of this class. We just don't have time for it. So what I might do, because I'd love to teach you all this, um, it'll make you very, very good at your job when you're dealing with cardiac patients and even trauma patients. But I may build a blood pressure class if y'all want, and we can do it at the boot camps. We'll just take an hour or so, maybe hour and a half tops, and we'll just go over blood pressure. Um, it's really, really cool to know, why did the pressure climb? Why did it fall? Why did the numbers get further apart or closer together? That kind of thing. Because that can really change your perception of what your patient's doing, and it might even get to the point where you change your treatment and actually, save the guy's life or something. Which wouldn't that be nice? Systolic blood pressure is the maximum pressure generated in the arms and legs during the contraction of the left ventricle. So first of all, you have your diastolic pressure, which I'm reading this backwards, but we'll do this one backwards. Just the blood in your system, just existing in the system is going to be your diastolic blood pressure. That's the amount of pressure that's on those pipelines just by having blood in them. So you guys that are firefighters, if you charge up an inch and a half hose, but you're not adding any more water to it or whatever. You've got your nozzles closed and you just put water in the system. That's your diastolic blood pressure. All right. Your systolic blood pressure is if you crank the pump up on the fire truck and now you're shoving water into the hose, you're throwing even more pressure into it. That's your systolic blood pressure. So your baseline is that second number. The force of the heartbeat is the difference between the two. And the number itself is the maximum pressure from that heartbeat. So knowing what the blood pressure numbers mean, you can kind of see why I say like you could take an entire class just on blood pressure and what that means, because there's so much information you can get from it, especially when you look at trends. When you look at what was the blood pressure when you arrived versus what was it 5 minutes later, 5 minutes after that, so on and so on. All right, your pulse. Everybody's familiar with the pulse. This is felt when blood passes through an artery during systole. Systole, that word right there means heartbeat. So if I say a patient is in asystole, basically just means they're flatlined, right? There's no heartbeat. So that's a term I want you to know, and it's used in a few things. That's why we call it the systolic blood pressure, is because that is the pressure at the heartbeat, at the point of the heartbeat. Peripheral pulses can be felt in the extremities. Central pulses are felt near the body's trunk. If your patient is alert and talking to you, you can get a peripheral pulse perfectly fine. Like I said, I personally want to see you guys taking both at the same time, especially if they are unconscious. If they're up talking to you, you want to feel the wrist and not the neck, that's perfectly fine. Nothing wrong with that. In fact, some other EMTs will tell you not to waste time with the neck, and it makes sense if they're awake. But if your patient is altered in some way mentally or if they're unconscious, check both. Central pulse is found near the body's trunk, so that's going to be your carotid, your femoral, your popliteal, those arteries. Well, actually not your popliteal, but your carotid and your femoral. So there you go. These are your pulse points. The big ones that we use, carotid and radial, posterior tibial and dorsalis, those are usually if they have like a broken bone in their leg and we want to make sure they're getting a pulse down there. Those are what we're going to check. Your femoral artery is fantastic if you are worried about a abdominal aortic aneurysm, or if for whatever reason you can't feel a carotid or something like that. And then brachial is what we use for children. Don't bother with a brachial for an adult, especially a male. You're probably never going to find that pulse. It's hidden. Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. So you have your stroke volume times your heart rate. So again, if the heart can't make a solid beat and it's, the stroke volume gets cut down, the only way to maintain your cardiac output is to up the rate. Vice versa, if the heart rate drops, the only way to maintain it is to up the volume of blood. So, but it's much easier for the heart, it's much easier for the body to pick up the pace than it is to try to make the heart expand more. It can do that, and there's terms for it, but again, that's where we start getting into like cardiologist level stuff. And I don't want to confuse anybody. Perfusion describes the constant flow of oxygenated blood to the tissues. So if you're awake and y'all are awake in this class, I'm awake talking to you, we have good perfusion. All right. You start to lose perfusion if you lose a lot of blood. That's what leads to shock. In fact, shock by itself, the definition is hypoperfusion, which means not enough oxygenated blood getting to the tissues. And that can be for any reason. It can be hypovolemic, where they bled out. It could be distributive, where the blood vessels got so big, or there's a problem with the vascular system to where their blood pressure dropped out too bad. And now the blood can't flow because there's no pressure. Anaphylaxis, which we'll talk about when we get into allergic reactions. Any of those kinds of shock, they all mean the same thing. It's just what's causing it is what's changing the type of shock you're dealing with. So good perfusion requires a well-functioning heart. If it's not functioning, then you are in cardiogenic shock. Appropriate heart rate allows the proper volume of blood to be circulated. You have to have an adequate amount of fluid. All right. So if you've lost a lot of blood, then you are in hypovolemic, which means low volume. Blood vessels must be appropriately constricted to match the volume of blood. If they dilate to the point where you lose blood pressure, that is distributive shock. If perfusion fails, cellular death occurs, and eventually the patient will die. We do compensate when we're like, if our body starts to go into shock, we do compensate for it for a while. Kids do really, really well, but they do it with they only have one way of compensating. So that will look great, but then when that compensation fails, there's nothing left. They just fall off a cliff, and now you've got what looks like a dead kid. So kids are the scary ones, because when you realize they're compensating, the problem is you have no idea when they're going to crash, and when they do crash, they really, really crash. Like you don't see it coming. They'll fall off a cliff. Adults, we have a couple different mechanisms as we get older to compensate for shock. So if you're watching an adult go into shock and they start to decompensate, you're going to actually see their vitals go like they're just rolling downhill. They don't fall off a cliff, but they're pretty steady with it. What is the rate of bradycardia? An elevated rate actually make you nervous? So at what point would that be a red flag to me? Is that what you're saying? It depends on the patient. Again, if I see a pulse rate of 40, that's a red flag for the average person, but not everybody. So saying an exact number would be a red flag is kind of hard because it depends on the patient. If it's one of my best friends, he is teaching the EMR class at the same time as us for my company, and his dad's I think in his 70s. I'm not really sure how old he is, but he ran triathlons for his entire life. So his resting, even though he's an elderly guy, his resting pulse rate's like 40, 44, something like that. That's some stupidly low number, and he's elderly. So if he ever complains of chest pain and the paramedic walks in, if the paramedic doesn't know him, he's going to think something's wrong. But the guy's just in excellent shape. And women sometimes have a higher resting pulse rate than normal. Like significantly higher, where if you just looked at the number, you'd be like, holy crap, that's really high. I need to do something to bring this down. But it's normal for the patient. But yeah, usually if we're talking about a normal run of the mill person, if they're more than 20 points out of their range, that's a red flag to me, unless there's a reason for it. Now for your book or for the test, I would say, no, you know what? We'll stick with 20 because the book, your tests aren't going to give you, a pulse of say 55 and then expect you to say that's bradycardia. That's close enough to normal that it's confusing, and they're not going to do that to you. If the book and the test, if the registry wants you to recognize tachy, they're going to give you some obscenely high number, like their pulse is at 122 a minute and something like that, and you're like, well, that's high no matter how you look at it. So um, don't worry about that. But yeah, I'd say 20. All right, next slide. Getting into the pathophysiology. Heart-related chest pain usually stems from ischemia, which means what? I know I said it at the beginning, so y'all repeat that back to me. What is ischemia? It is also on your slide. It's a decrease in blood flow to the heart, specifically to the heart. Um, yeah, no, the variance is very wide. You're right. You're absolutely right. Because it's the body doesn't work to maintain a set pulse. The body works to maintain a set blood pressure. And if that means keeping the pulse high, you keep the pulse high. So we have a range that we consider good, but that's why it's a 40-point range. And then even then, the little fudge factor at the top and bottom is pretty large as well. Anyway, so to the pathophysiology, chest pain usually stems from ischemia, which means that the heart itself is not getting enough oxygen. And that can be from a couple things. It could be from any of the shocks we talked about, where like, you either don't have the blood flow, or you do have the blood flow, but you don't have the oxygen, or you got plenty of blood flow, but the coronary arteries are blocked. So blood's not getting to the heart, that kind of thing. That's going to cause you chest pain, and it could be any one of those. Um, Ischemic heart disease involves a decreased blood flow to one or more portions of the heart. So depending on which coronary artery is blocked, that particular part of the heart's not going to get oxygen. If the heart, if any part of the heart goes for so long without oxygen, it's going to die. That tissue is going to die, not the whole heart, but just that one spot. That is called a heart attack. All right, where a section of the heart muscle dies out because it's too hypoxic. It didn't get the oxygen it needed. The carbon dioxide built up too high in it, got so acidic that the cell basically popped. And now that creates a problem because when a cell dies like that, it releases all this necrotic, nasty, toxic to acidic junk into the area around it. And guess what? All the other cells around it are going to start to get that as well. Not to mention the fact that they're not getting oxygen either. So you can see how the problem starts to fester and spread as it gets worse. Have you seen people with excessive stressors have a nervous system issue that cause shock? Not shock, no. Have you seen people with excessive stressors have a nervous system issue? So if the question had stopped there, I would say yes, but I haven't seen it actually cause shock. PTSD can do it, can cause nervous system issues. You'll see people develop a tic, an eye twitch, like a little nervous neck twitch kind of thing. Those are, yeah, I mean, you can do that. That is normal. I've seen that happen to a lot of military. I've seen that happen to a cousin of mine who I don't even know what it was that caused it. He's never been military. He just, I don't know, whatever, something he was going through in his life when I was too young to know any better. He's got a pretty big tick in his neck. He'll be talking to you and he'll just kind of like twitch his head to the side. Um, I see what you're saying. So maybe like a burnout issue could cause it. It could make it to where the receptors don't respond like they should. Um, but I don't think it would. I've never seen it get to where I would consider it to be shock. At least not shock like I want you guys to think of shock in this class. On this slide, atherosclerosis is a disorder in which calcium and cholesterol build up and form a plaque inside the walls of the blood vessels. This is usually caused because people don't eat right. All right, but that's not the only case. Sometimes stress will do this. Genetic factors will do this. Sometimes you got the short end of the stick from your family and you are predisposed to this. It's not anything you did wrong. It can cause a complete occlusion or blockage of a coronary artery and other arteries of the body. So a couple things can happen here. One, it can just grow to the point where it completely seals off the artery. Two, a piece of it might break off, and now you have a thrombus, and it's going to be floating through the bloodstream and everything until it gets into a passage that's so small it can't fit. And it's just like choking on a piece of steak, except this artery is now what's being choked. Depending on where that's at, that can cause quite a few problems, right? If it gets stuck in your legs, it won't kill you, but at least not directly, it won't. But it's going to cause a lot of pain. So you're going to get people that tell you they've got extreme pain in their leg, and their leg is red hot to touch, and it's swelling, and there's all these. You're like, oh, there's something wrong with the leg, all right? And then they tell you they had surgery a week ago. So now you know they're recovering something, or they're recovering from a big issue. They probably blew a clot and were lucky, unfortunate enough for it to happen, but lucky enough that that's the direction it went. And if you get them to the doctor fast enough, they can remove the clot and save the leg, that kind of thing. So you'll be, all right, let's go. We're going to get them in the truck and go, kind of thing. Some people aren't so lucky. Sometimes the clot winds up in their head and they wind up with a stroke, or it winds up in the coronary artery and they wind up with a heart attack. It just depends on where the clot is and what direction that blood is going. Fatty material accumulates as a person ages, resulting in the narrowing of the lumen, which is the inside of the blood vessel. Where he talked about the thrombus, it's a blood clot that flows through the blood vessels. Depending on where it gets stuck, you're going to have problems in that area. Another issue is infection, right? The body might see a plaque, a piece of plaque thrombus as an invader, and so it's going to treat it like an infection. Infarction, if you ever hear that word, infarction means the death of tissue. So an AMI, I keep saying heart attack, but an acute myocardial infarction, that basically is saying that the cells in that area have died in the heart. Some controllable factors: cigarette smoking, high blood pressure, elevated cholesterol levels. So the way that we eat, who in here knows that your cholesterol is divided into two groups? Yeah, and I learned that I learned this later in life than I care to admit. But there's two kinds of cholesterol. All right, cholesterol is not bad in itself, but one kind is. So you have your LDL and your HDL. One's low density, the other is high density. Which one is good for you? We need cholesterol. Cholesterol is what helps our cells on a cellular level, helps our cells maintain their walls, the cell walls. Okay, good. Yeah, y'all got it. H for healthy, L for loser. The LDL is the kind that we don't want. That's what you get from a crappy diet, or lethal. That's a good one. But yeah, your HDL cholesterol is good for you. It's like you've ever heard good fats. That's kind of the thing, and it's good for your cells. It helps your cells maintain their permeability and their function better. That's something that if you guys go through a real A&P course, not an EMT watered down course where we focused on what we needed you to know, but if you go through the full thing, you'll learn all about that. Elevated blood glucose levels, lack of exercise, obesity, all of these are controllable factors. Your uncontrollable factors, you have older age. If anybody ever figures out how to control that one, let me know. Family history of atherosclerotic coronary artery disease, race, ethnicity, and male sex. Sucks to be a guy sometimes. Acute coronary syndrome describes a group of symptoms caused by myocardial ischemia. So again, remember, ischemia means lack of blood flow to the body or to the heart. So um, this includes temporary myocardial ischemia, resulting in angina pectoris, which is chest pain, or a more serious condition, which is an actual heart attack. Um, think of these like strokes for your heart. All right, if you get a piece of plaque that blocks off coronary artery, every time the heart beats, that piece of plaque is going to get hit by the systolic blood pressure. Um, if it's not much of a blockage, if it doesn't really get stuck, or if it breaks apart or whatever, you might wind up having the chest pain, the angina pectoris, because it happened. But then for whatever reason, it either broke apart or it got knocked loose. Now blood flow gets restored. Everything goes back to normal. Yay, they live. And you're stuck at the scene scratching your head why it looked like they were having a heart attack, but now they're fine. But sometimes that doesn't happen. Sometimes they really are stuck with it and they have to go to a cath lab at the hospital to get it removed. Angina pectoris occurs when the heart's need for oxygen exceeds the available supply, usually during physical or emotional stress. You don't have to be having a heart attack to get this. All this means is chest pain. You run a marathon when you really aren't. You're still more on the couch than the 5K side, and you get out and run. If you haven't really built up your cardiovascular system, when your heart starts to beat heavy, um, you're going to get chest pain from it. All right, so it's a crushing, squeezing pain. If anybody's ever ran in the cold or ran in different altitudes, you probably run into this problem. You have a perfectly healthy heart, but you're still exceeding the supply. I'm sorry, the demand is exceeding the supply. It doesn't usually lead to death or permanent heart damage. It just hurts. You're sitting there like clutching your chest, like what is wrong with me? And then it goes away. Should be taken as a serious warning sign, especially if you didn't do anything to cause it. If somebody's out running and they're just getting into shape or whatever, that's that's normal. That's not really a red flag. But if somebody is sitting there in their recliner watching Jeopardy and then they get it, that's a much different situation. All right, so let's talk about the difference between stable and unstable. Unstable angina occurs in response to fewer stimuli than ordinarily required to produce angina. So um, there's only a couple of things that can cause this. Stable angina is relieved by rest or nitro. So again, if you're out running and your chest hurts and you stop moving and the chest pain goes away, that's stable, right? Unstable is my chest hurts, I'm going to give myself a nitro and the chest pain goes away, that's stable. If you take nitros and nothing happens, that's unstable. Then we don't like that, right? That means there's something else wrong. Um, and we need to get that fixed. So they're going to be going to the hospital one way or the other. Treat angina patients like heart attack patients because we really can't diagnose it in the field. So when in doubt, just take them to the hospital. All right, it's 7 o'clock. Take a 10-minute break and we will resume pretty much right where we left off. All right, let me get the show back on the road. So basically, the pain, whenever you feel pain from a heart attack, that signals the actual death of cells in the area of the heart where the blood flow is obstructed. Not to be confused with angina pectoris. That's pain, yes, but it's not. It's not the pain of the AMI. The AMI is the progression from there. Once dead cells don't come back, all right, that's not. We don't regenerate. Well, I think one part of us does, but it ain't the heart. They'll turn to scar tissue and become a burden to the beating heart. And if it doesn't all the way through, there's always that chance that the heart might blow the scar tissue off, and now you've got a hole, which can cause some issues like low blood pressure, death, that kind of thing. About 30 minutes after blood flow is cut off, some heart muscle begins to die. And now, for any of you who take this EMT certification and you go into a hospital instead of an ambulance, you're going to be running labs on patients with heart attacks. So, if you ever hear the term troponin, that is basically just protein sitting around in the bloodstream that's coming from dying or dead cardiac tissue. Um, they'll do it in the hospital. They'll run CBG or some kind of blood test on a patient, send it off to labs, and one of the things they're looking for is if there's any of those proteins in the bloodstream. That's one of the definitive signs that they have a heart attack of this sort. So After about 2 hours, as many as half the cells in the area may be dead. 4 to 6 hours, you're looking at more like 90% of the cells will be dead. Opening the coronary artery with either a clot busting drug or like a thrombolytic or angioplasty can prevent permanent damage if it is done within the first few hours after the onset of symptoms. So time is essential, no matter whether you're a EMT, paramedic, whatever. We don't fix this in the field. We stabilize in the field and then we get them to a hospital. Immediate transport is essential. It's more likely to occur in the left ventricle because that's the big muscle. That's where most of the wear and tear on the heart comes from. Not only that, but because that's your bodybuilder portion of the heart. If you don't, I hate to keep harping on lifestyle and everything, but that's just a really common cause of this. If you wind up with hypertension, which is high blood pressure, and your heart's beating against a high blood pressure on the left side for very long, it's going to do like any other muscle does when you put a lot of strain on it. It's going to get bigger, right? That's why we go to the gym to build our muscles up and stuff like that. Your heart's got the same attributes. Um, if the heart's trying to push against a high blood pressure system for too long, the heart muscle is going to grow. And then now we start to run into that problem where you only got so much room, so much room outside the heart and only so much room inside the ventricles. When that muscle starts to expand, you're cutting down on that space. That's going to cut down on your stroke volume, which cuts down on your cardiac output. It's a bad progression of things. So keep that in mind. Some signs and symptoms of an AMI: sudden onset of weakness, nausea, and sweating, chest pain, discomfort, or pressure that is often crushing or squeezing that does not change with each breath. So they're going to feel like they got an elephant sitting on them or something like that. And there is no making it better. If they sit up, it's still going to be there. If they lay down, it's still going to be there. If they try to change their breathing, it's still going to be there. Pain, discomfort, or pressure in the lower jaw, arms, back, abdomen, or neck. And I'm going to add the epigastric region, which is right below the diaphragm. For women. All right, they have that weird deferred pain, and so it doesn't quite fit the mold of what we hear as classic cardiac arrest, or not cardiac arrest, classic heart attack signs. A woman is more likely to tell you that she has some indigestion than she is to tell you that there's pain going down the left arm. Irregular heartbeat and syncope. You don't necessarily, as an EMT, you're not going to hook up a monitor to somebody, but if you're feeling their pulse and their pulse isn't regular, which means it feels like it's either skipping beats or it's just not beating in sync. That's a sign. Syncope means fainting. There's a couple different things that can do that. It's not just cardiac, but that's a sign for cardiac. Shortness of breath, nausea, vomiting, pink frothy sputum. So now we're talking about CHF-like symptoms, and then sudden death. Sudden death can happen. There are people out there that will have a heart attack and drop dead on the spot. It just depends on where the problem is at. There's a certain part of the coronary artery that if it gets blocked at that point, it's called the widowmaker because it's going to kill you. Like that's, brother, we can't get you to the hospital fast enough. We're going to be doing CPR. Kind of sucks, but it's rare. That doesn't happen very often, but there is that one just weak spot in the design, basically, where if that's where the problem's at, we're pretty much dunsies. The pain of an AMI differs from the pain of angina in three ways. Let me get to the right slide. First of all, it's not always due to exertion, right? Like I said, if a guy's sitting there watching Jeopardy in his recliner, and he gets angina, that's not, or he gets chest pain, that's not typically angina pectoris. That's probably more of a heart attack. Let's see, that's what happened. I'm sorry to hear that. I lost my parents too. I actually lost my dad to CHF, and I was a little ticked about it. I don't mind this being in the recording. I was a little ticked off about it because I was away at SEER with the military, and certain family members, and it's not really their fault. I don't blame them for it, but I really wish, because I deal with CHF on a daily basis almost, I really wish they would have told me the different signs they were seeing from my dad. Like he would cough a white frothy sputum, he would get out of breath walking from the car door to the front door, all these things that probably should have meant, hey, send them to the hospital, but they didn't do it. They just thought he was getting old. That was their thinking because he was getting in his mid to upper 40s, um, and wound up being congestive heart failure. So, oh, you just worked? That sucks. Wait, you worked a sudden death cardiac heart attack, or you worked just a heart patient? If like I was about to say, if you're typing a novel, dude, you can unmute. Seen it once in the hospital. A guy standing at elevator, dropped stone cold dead. Yeah, yeah, it's crazy. I mean, it's almost like you see the guy breaking his neck in the movies, and how they just drop out, and that's it. That's pretty much it. There's no warning. Um, you pretty much go straight to CPR, and no measures of support brought him back. No, no, no. Well, I mean, if he's on his way to the cath lab already, and they're already set up, they might be able to. But um, oh wow, that sucks. That's not the way I want to go. I mean, I don't want to go at all, but I can imagine just dropping dead in front of everybody. I don't want to. All right. So another difference, the pain doesn't go away. So usually angina pectoris will go away after a little while, but if the pain is persisting, if it's been there like 30 minutes, several hours, it's not angina. That's probably a heart attack. Um, and it may or may not be relieved by rest or nitro. So nitro can fix angina. Nitro cannot fix an actual, honest to God heart attack. That pain is going to be there because of what nitro does and how it works. So don't think that nitro is a cure all. Nitro does not fix a heart attack. All right, it's not what we're giving it for. We're giving it for pain relief of angina pectoris. Not all patients who are having an AMI experience pain or recognize when it occurs. And when called to a scene where the chief complaint is chest pain, complete a thorough assessment. Make sure you get a blood pressure, especially if they have nitro. No matter what the patient says. If it's a legit heart attack and they have a sense of impending doom, they're gonna be begging and pleading with you to help them. But if it's angina pectoris or something of that sort, they might fight you. Be like, no, I'm fine. It's just heartburn, or or whatever. Do a thorough assessment. Physical findings of a myocardial infarction and cardiac compromise can include being frightened. So their general appearance, you're gonna see frightened, nausea and vomiting, a cold sweat, pale or ashen gray skin, cyanosis, which is blue skin. So again, remember that's a late sign. That's the first thing we're seeing. We're already behind the curve. For their pulse is going to be faster, especially when they start to get into pain or if they start to freak out about it. Their pulse is going to pick up. If their blood pressure starts to drop, their pulse is going to pick up. Irregularity or slowing pulse, that's the problem. All right. The normal progression is going to be their pulse is going to climb first and then it's going to drop. So if you get there and they're already starting to lose their vitals, it's like cyanosis. The race already started. You just showed up to the start line a little late, so you got to catch up. Bradycardia due to damage to inferior area of the heart. For their blood pressure, I'm on the same slide. Okay, so this is slide still. For their blood pressure, the pressure could fall because of reduced cardiac output. As long as their pulse is able to pick up, then great. All right, they'll maintain a decent blood pressure. But the problem is it's kind of like shock. At that point, the heart's having to work harder to maintain a failing system, and if the system's not working right, that means the heart's not going to get its oxygen like it should, and it's just going to tire out that much faster. Most AMI patients will have a normal or possibly elevated blood pressure, and then it'll start to fall. It kind of follows the same path as shock. Respirations are normally normal. All right. A heart attack doesn't really mess with your respirations until you're really, really late in the game. At that point, they're circling the drain, going toward cardiac arrest. If a patient has congestive heart failure, though, you will see a difference in their breathing. They're going to start to pick up the pace because they're trying to get air to the system. Um, as that fluid starts to push into their lungs, now you're going to start to see frothy sputum coming out of them. That's a respiratory sign. So if you do see, if they're giving you a scenario that sounds like heart attack based on what they're saying, but you're seeing respiratory issues, that's usually congestive heart failure. And if that's the case, it's the respiratory issues that we should be focusing on first, because that's your primary assessment. Fix their airway, right? So BVM them, CPAP them, whatever you need to do, get their airway fixed. And then we start, once you get that under control, then we move to the heart and we can give them some nitro to open up their blood vessels, have somewhere for all that fluid to go when it gets out of the lungs, that kind of thing, which we'll talk about that later in the chapter when we start talking more about the different issues. For their mental status, confusion, agitation, remember, keep in mind, first thing to mess up when something gets wrong with oxygen delivery to the brain or the rest of the, or mainly to the brain, is their mental status is going to kind of get crazy. And then you are going to have the feeling of impending doom. All right, 3 serious consequences of a heart attack. Yeah, sudden death, cardiogenic shock, which again, when we talk about the different types of shock there are, if there is a problem with the heart, with the actual pump, it's cardiogenic. That's hence the name. And then congestive heart failure. All right, so dysrhythmia describes an abnormality of the heart rhythm. Normally, your heart should beat steady. All right, beat, 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 beat. If it picks up the pace for whatever reason, that's fine. If it lowers the pace, that's fine. But it should be a steady, like clockwork. It should hit. Oh, I missed a question. I'm sorry. How do we explain the patient who goes to the ER or PCP for unrelated issue and finds out they had a heart attack in the past? Depending on where the heart attack was, it may not have been a life threat. Remember, heart attack just means dying cells or cell death because lack of oxygen to that area. If it was something along the lines of angina pectoris, where the clot broke itself up and blood flow restored on its own, so no real effects from the cell death. Well, I mean, it depends. How massive heart attacks, they're not going to just come out of that on their own. Usually, that's the problem. But yeah, if it's small, let's say you had a coronary artery blockage, but it was all the way down at the end of the coronary artery, and only one small little section of the heart was affected, and it's way down by the apex, and it's in the septum, something like that. That's a big piece of muscle that's in the interior of the heart. It's not that it doesn't really contribute to anything other than separating the ventricles, that kind of thing. They might not ever even notice they had that. Will something small trigger? Yeah. On the monitor, a paramedic can see it. There, and we can talk about that at boot camp too. I don't want to get too far off in the weeds, but yes, if there's any kind of ischemic heart issue, typically what you're going to see is ST depression, if you know what that is. Bundle branches, you can see if there's an issue there, you can see that. So yeah, I mean that's paramedic level, but yes, you can see it. If it's we have STEMIs, which is ST elevation, tells you that they're having a heart attack. But if it's ischemic, then it's actually going to be below. Yeah. Like I said, I don't want to get too far off into it, but yeah, depression is a sign of ischemic heart issues. So anyway, back on this, dysrhythmia describes an abnormality of the heart rhythm, like I was saying. So if you hear like you're knocking away and then you miss a beat and then it keeps going, or you're going and you catch a beat comes in too soon or something like that. Anything out of the ordinary, anything out of that metronome is a dysrhythmia. So you have premature ventricular contractions, tachycardia, bradycardia, ventricular tachycardia, and ventricular fibrillation. Those last two are shockable rhythms, if you've ever heard that. So when we hook up an AED to somebody, it is looking for those two rhythms. You don't shock PVCs, you don't shock tachycardia or bradycardia. You shock VTAC and VFib. So Fibrillation, that's where the heart's just quivering. There is no organized rhythm. If you see that, if you ever look at a paramedic's monitor, it just looks like a bunch of squiggly lines. There's no rhyme or reason to it. That's VFib, and we can shock that. An AED will detect that rhythm and it'll pop the patient. VTach is tachycardia, so it's a fast heart rate that is starting in the ventricles, which means that the heart is no longer listening to the SA node. If you ever actually look at a heart rhythm, if you're looking at regular like sinus tach, for example, you're going to see the little blip on the line that shows that the SA node fired, and then you're going to see the rest of the heartbeat following it. If you don't see that, and the complexes are wide, usually they're going to be wide in this case. That's called ventricular tachycardia. That means that the heart is we can just say that the heart's racing and it's not paying attention to the SA node. Remember, the heart's going to follow the fastest pacemaker. So you guys ever watch those movies where it's like the rescuer jumps into the water to try to save the guy, and the guy's freaking out, and so the rescuer just backhands the dude, just slaps the shit out of him, and like stuns him for a minute, and the guy's like, "Oh, okay, what are we doing?" That kind of thing. That's what the AED is doing in this case. The heart is racing off, not listening to the SA node like it's supposed to. So basically, when the AED detects that rhythm, it's going to shock it, stuns the heart for a second, says stop and listen, and hopefully the SA node is working. The SA node is now the fastest heartbeat again, and the heart will be like, okay, there's my rhythm, and pick it back up. Most of your cardiac arrests start with these problems. That's why we say, early defib. Let's get in there. If we can fix these two rhythms before their heart actually stops, before they lose their pulse, an AED shock may be all they need, and you don't ever have to do a single compression. That's a goal. All right. That doesn't always work that way, especially with us not even getting the 911 call until the patient's already unconscious on the ground. But I mean, that's if we can get there, if we witness cardiac arrest, we might be able to bring them back with just the AED. So another example would be pacemakers. Pacemakers can kind of fix that. They also have internal defibrillators. There's all kinds of nice toys out there that cardiologists can put into patients that makes people be able to live with problems with this stuff, and they just go about their daily life, just with an occasional jerk when the thing shocks them. So defibrillation still restores cardiac rhythms. Again, we were talking about it. Defibrillation only restores those last two. Those are your only two shockable rhythms. You don't shock asystole. We don't shock bradycardia. We don't shock tachycardia. We only shock those two rhythms. So just know that in AED, automated external defibrillator, what that thing does when you hook it to the patient is it says, am I looking at VTach definitively? If yes, cool, shock them. If not, okay, we'll toss that one out. Am I looking at VFib definitively? If yes, cool, shock them. If not, toss that one out. Those are the only two shockable rhythms. At that point, the AED would say no shock advised, continue CPR. That's how the decision making works in an AED, because those are the only two rhythms. If you are touching your patient when the AED is analyzing, it might see VTach or VFib, but it's also going to see your rhythm. And so now it doesn't know for sure. It's not definitively VTach or VFib. It may say no shock advised when it really needed to. That's why it's so important to clear your patient, not just for the shock, but also for the analyzing stage. You want to make sure that it's only going to see what it needs to see and it's not going to pick up anything else. Asystole, we talked about this earlier. Anything that starts with A means without. So this is without a heartbeat. There is nothing there. It's just a flat line. It usually reflects a long period of ischemia. And nearly all patients, if they get to this point, they're probably going to die. Like there's really probably not going to get them back. Cardiogenic shock occurs when body tissues do not get enough oxygen. It's usually causing body organs to malfunction. And actually, before we get into this, I want to go back and talk about asystole and the opposite of it for a second, because it looks like we're moving on without it. Asystole means, oh, okay. Um, Asystole means no electrical rhythm. All right, that's bad because if there's no electrical rhythm, that means there's no heartbeat. But there's also something called PEA, or pulseless electrical activity. That's not a rhythm, that's a finding. All right. In other words, if you were to stare at the if a paramedic hooked up a monitor and you looked at your practically dead patient on the ground that is needing CPR, you look at the rhythm and you see a rhythm. There, the everything is there. It's trucking along nice and pretty. This guy should be sitting up talking to you, but he's not. That means that he has the electrical activity, but there's no pulse. If you see that, just keep beating on the chest. All right, we're going to continue CPR. You don't shock PEA because the electrical system's already there. The shock's not going to do anything. What's missing is the hydraulic response to it, so there's no blood flow. A lot of times, what that means is that for whatever reason, the SA node is either severed for something. The connection, like there's some kind of block right up by the SA node, is not firing off anymore. And it could also be, we call them the H's and T's in paramedic world. And basically that's just a couple of different things that are reversible causes that we can actually try to fix that might pull a patient out of a PEA. And it's usually, we're doing this while CPR is going because they got to have a pulse. If they don't, we're going to give it to them. So we're going to have somebody doing CPR and we're going to be trying to figure out, well, are they hypothermic? Was there a thrombus? That kind of thing. So those are the things that can cause that. I wanted to talk about that because it doesn't look like they're going to put that on the slide, but you may see that in the registry, and I guarantee you, if you work in this field long enough, you're going to come across it in the real world. I don't want you to be just dumbfounded by the fact that you see a pulse, or sorry, you see a rhythm, but you have no pulse. And then, oh, okay. So what I was saying was, asystole is usually, it reflects a long period of ischemia. So if the heart went without oxygen for too long, it's no longer going to respond. All the cells are pretty much knocked out. It's no longer going to respond to the electrical stimuli. So you wind up with asystole. All right, cardiogenic shock occurs when body tissues do not get enough oxygen, causing the body organs to malfunction. It's often caused by a heart attack. That's why anytime you see cardiogenic, that means it's the heart that's causing the problem. The problem is in the heart. The heart lacks the power to force enough blood through the circulatory system. It is more common in a heart attack affecting the inferior or posterior regions of the left ventricle. Most of the time, your heart attack is going to be in the left ventricle. That's just the common area for it. It can be posterior, it can be inferior, it can be right-sided, but usually it's going to be on the left ventricle. It's important to recognize shock in its early stages. That line right there should probably be at the top of the slide. Can we reverse shock? As EMTs, can we reverse shock? No. I like that. You're like, probably not. I tell you what, I will unmute Don and tell me what you were thinking. Not that it's a wrong answer, but maybe I'm wording it wrong and I'm missing something. But what, in your experience, have you ever seen somebody actually reverse shock that I'm not thinking of?
You mean reverse it as an EMT station?
At any level. Well, I'll say at any level in EMS, not necessarily in the hospital.
No,
Not
not
really.
really. No,
No.
I mean, you can, increase their volume, giving them IV fluids, but we're not reversing shock.
Right.
You're making them, you may make them have better vital signs, but you're not reversing the shock. That's a lot of time and fluid replacement.
Yeah, and that's the thing. So like,
Yeah.
even if
Heart casts and all kinds of stuff.
yep, even a paramedic, if he shows up and a dude's in decompensated shock, he can flood him full of fluids, but it's not going to. Fluids don't carry nutrients, right? So if I were to hook somebody up and push a couple liters of fluid into their veins, I can give them a blood pressure, If that's the problem, then fantastic, I did reverse that, but that's usually not what's causing the shock. Um, the problem is hypoperfusion. There's not enough there's not enough red blood cells to carry oxygen to the body, or there's something stopping them. Um, we can't reverse a shock. We can reverse something that might be causing the shock. And if we catch it early enough, um, then we can stop it from getting too far. But that's what they're meaning by that. So it's very important. If you look at your assessments, you see that treating for shock is way up at the top. Not like scene safety level, but it's one of the first things you do once you get to your patient is try to recognize and treat for shock. Because typically, especially for the EMT, you guys can't give fluids. Y'all can't. There's a couple things that you can't do. Um, the best thing that we can do is be proactive and stop it from getting bad in the first place. Because once it gets there, we really can't get it back. And even in the hospital, even at the advanced level with paramedics, it's hard to nearly impossible to get somebody back, especially once they've reached decompensated. That's pretty much they really need to be in the hospital where they're getting blood transfusions and all that stuff. I agree, but I also understand why they don't let you guys do it. Um, when you go on when you go on to the advanced and we teach you IVs, we teach you about infiltration. Um, well, yeah, because at that point, they're probably gonna die anyway if you don't do it. Um, I did 1,000 IVs in the army. Yeah, no, I've done a few to say the least, but dude, I'm not gonna talk smack in the middle of the class. But yeah, as a medic in the Air Force, I did a lot as well. Um, before patient for no reason. Oh, before PT for no, yeah, for no reason. Absolutely none. Can't think of a single reason why I might need to hook all my buddies up with an IV before we reported. Can neither confirm nor deny that one. Anyway, moving on. So CHF. Let's talk about CHF. CHF occurs within the first few days after myocardial infarction. A lot of times, patients that have had a heart attack will start to have to fight with this. CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart function. So, diseased heart valves, chronic hypertension, any of these things can kind of exacerbate it. It's called congestive because the lungs become congested with fluid. So, again, the biggest issue with this for you as an EMT is usually going to be fighting to clear their airway first. That's the problem with this. Is like it's a heart issue, but we have to fix their breathing. We have to fix that problem before we can even get started on the heart. This may cause dependent edema, which is basically just blood pooling. This can occur slowly or it can be sudden. It just depends. Um, in acute onset CHF, severe pulmonary edema is accompanied by pink frothy sputum. You're going to see them coughing this crap up. Fluid may also collect in other parts of the body, so like their feet. Think of it like lividity when you die. When the blood flow can't move like it's supposed to, gravity starts to take its effect, and the blood will start to kind of pool out, and it'll collect in your lower extremities, so you're going to swell. Hypertensive emergencies. Hypertensive emergencies involve any systolic blood pressure greater than 180. All right. High blood pressure is a thing. A lot of people have it to the point where they're even getting ready to change the baseline numbers that we teach in school to be a higher than normal. Common symptoms: strong bounding pulse because your heart's having to really hammer it in to get that afterload like it's supposed to be to give you some kind of a pulse, because otherwise the high blood pressure is too much. The blood wouldn't move if the heart didn't try harder. Ringing in your ears, nausea and vomiting, dizziness, warm skin, can be dry or moist, but typically warm. A nosebleed because the high blood pressure is probably going to start popping capillary beds. Altered mental status and a sudden development of pulmonary edema. Again, popping capillary beds, especially around the alveoli and the lungs, you're going to start to get fluid in them. Untreated hypertensive emergencies can lead to stroke or dissecting aortic aneurysms. Anybody ever heard of an aortic aneurysm?
My physician had one on the ski slope in Utah and survived, actually.
Oh, wow. So it didn't rupture.
Apparently not. They said if he hadn't been right there by the hospital, whatever that, let's call it, where the,
Yeah, it's
uh,
those things are no joke. So
yeah, Utah, whatever.
for those that have never heard of an aortic aneurysm, or may have heard of it by name, but they never learned anything about it. Your aorta, I know we always see just the lump of it coming across the top of the heart. Basically, if you follow the aorta all the way, it comes up from the left ventricle. It goes, you see it curve across like you see on the heart pictures, and it runs behind the heart, between the heart and your spine, basically, goes all the way down to a little bit below your belly button, and then it branches off and becomes your femoral arteries that go down each leg. This is the highest pressure, biggest artery in the body. And just like anything else under constant pressure that might develop a weak spot, it can pop. So think of a tire. All right, we keep them full of air, and if there's ever a weak spot in the tire, that air might start to push out right there, and it causes a little bubble like an egg. If anybody's ever heard of that, um, when that's all you've got, that's an aneurysm. All right, so that's already you're in a bad spot, but that's your aneurysm, and it can be abdominal or thoracic. Just depends on where on the aorta it's at, where it is. The presence of it is not going to kill you, but the rupture of it will. If you have an aortic aneurysm and it pops, you've got about 6 to 10 seconds to say your goodbyes, and at that point, you're going to have bled out, and there's nothing left. There's nothing we can do for you. The amount of blood that will come out of your aorta at that point there's no way. And that is pretty much certain death. So a lot of times we airlift aortic aneurysms, because we don't even want to chance the bumps in the road causing these things to pop. So we'll call helicopters when we can. If there's no other choice, take them by truck. But those of you that drive the trucks, keep that in mind. If you're carrying an aneurysm patient, try not to hit the potholes. Um, they'll go in, they'll put a sleeve over it or something to reinforce it so that it doesn't pop, but they got to get to the hospital. If it pops before they get there, they're pretty screwed. Um, and while I'm on that, if you guys are ever curious if your patient has an aneurysm, if they're, because there's certain signs and symptoms that kind of make you think that they have one. When you check your pulses and your blood pressures, get it on both sides of the body. Get both arms, get both. If you're checking on the legs, get both legs. Um, because what will happen, the blood is flowing through. When it hits the aneurysm, it's going to cause turbulence on one side. Whatever side of the artery that aneurysm, that bulb is on, it's going to cause some turbulence because it's going to slow down. Blood's going to kind of kick around into the bulb. Now it's even if it's not going slower, it's going further. So it's going to kind of create a slowdown, and now the blood is not moving streamlined all the way through like it should. So if the aortic aneurysm is on the right hand side, um, you're going to see that. You're going to see a difference in the vital signs on that side. It could either be like a diminished pulse, blood pressure differences, that kind of thing. Um, Whereas the side opposite the aneurysm is going to be more normal because the blood on that side is not getting messed with. Just something to think about when you're looking at your vital signs. So if you run into hypertensive emergencies, like I was saying, especially for aortic aneurysms, get ALS en route. All right. Talking about well, there we go. Your aortic aneurysms are all right here, just everything I just said. So susceptible to rupture. If it does rupture in the field, your patient is screwed. Do everything you can to not let that happen. Dissecting aneurysms occur when inner layers of the aorta become separated. So you saw a few slides back where it showed a cross cut of a artery, and you had the different layers to it. If there becomes a rip on one of those inside layers, and as the blood's going through, it starts to pull that rip down. Blood starts to shoot kind of between it and the rest of the walls. That's called a dissecting aneurysm, and it hurts, hurts, hurts. Your patient will tell you it feels like they're being ripped apart. So if you ever get, when you're doing your OPQRST, talking about, describe the pain to me. Um, if they're having an aneurysm, one of the most telltale signs, kind of like that impending doom for a heart attack, they're going to tell you it's a tearing sensation. It feels like they're being ripped apart. Anything along those lines is 9 times out of 10 it's a dissecting aneurysm. It's like a very specific kind of pain. Primary cause is uncontrolled hypertension, so high blood pressure. All right, 7:46. We got a little bit more time to go before we get to the next break. So we're going to go ahead and work on the scene size up and everything for your patient assessment. So we've gone over a lot of the issues that will go on with the patient for cardiac reasons. Now we're going to talk about how you're going to put this into your assessment. Scene size up doesn't change. BSI scene safety is the very first thing you will ever do or say, be it in the field or in the classroom. Ensure the scene is safe. Make sure you're wearing your gloves or whatever else you need. Determine your nature of illness. All right. Use information from the dispatcher with a grain of salt, but I mean, like I said, they do the best they can with what they're given. Clues at the scene and the comments of family members and bystanders, especially if your patient's unconscious. For your primary assessment, form your general impression. This usually boils down to sick or not sick. If your patient tells you that they have chest pain, that doesn't, and they look fine, that doesn't mean they're not hurting. All right, they're not lying to you if they just say their chest hurts, but it may not be a heart attack. If you look at your patient from across the room and he looks like he's about to literally die on you, well, then that's a major problem. That's a poor general impression. Just remember that that is your opinion of how your patient looks. If they look serious to you, then they're serious. And again, we even at the paramedic level, we sum that down to sick or not sick. All right. Assess your patient's airway and breathing. If they've had syncopal episodes, which is that dizziness and fainting, if it's due to cardiac compromise, consider the possibility of a spinal injury from the fall, especially if you didn't see it. If it's an elderly patient, that kind of thing. So again, we talked about it. Pretty sure we talked about it, unless I dreamed it up, or maybe I'm thinking of a different class I taught. But we talk about, when would you put a C-collar on somebody for a medical call? And it is usually, like I think I use the example of if you came into an elderly person's house to do a welfare check, and you find them laying on the ground, no sign of trauma, but they're laying down, and it's like it's an elderly woman. You can't rule out trauma. You don't know that the fall itself didn't hurt her neck. So when in doubt, put a C-collar on. That's okay. Assess breathing to determine whether the ailing heart is receiving adequate oxygen. So we know our breath range for an adult is 12 to 20, but we also know, because we're good EMTs, that we don't just go with the numbers. That was something that I used to see a lot in the boot camps. People get, because we want you to know those numbers, but people will forget that that's just part of the equation. So make sure you guys are getting context with that it's not just 12 to 20. It's got to be 12 to 20 with adequate breath, equal rise and fall of the chest. They got to look like good breaths. Shortness of breath with no sign of respiratory distress. If the oxygen saturation is less than 95%, you're going to give them oxygen on the cannula. If they don't improve quickly, you can just up the oxygen. Remember, we try to keep it 94 to 99. So if it's less than 95, that would be the 94. If it's over 100, or if the O2, if the pulse ox is saying it is 100%, back them down a little bit. We don't want to give them too much, and that reading stops at 100. Doesn't mean that that's exactly what you're giving them. I don't know who that is. Okay. For pulmonary edema, if you worry that they may have some fluid in their lungs of some sort, be it CHF or bleeding or any of that sort, use a BVM or CPAP. CPAP is fantastic. CPAP is like the greatest thing since sliced bread for this. However, your patient has to be alert. If they're already circling the drain on their mental status, you're going to have to use a BVM. If you can put oxygen on it, it'll just help the patient. All right, so for circulation, again, it's not just the rate, get the quality as well. Remember, it should be a normal beat. If it's too hard, we call that bounding. If it's too soft, if it's like you're feeling it, you feel it, but it's barely there, we call that thready. All right. Your cap refill is good for trending only. Don't get caught up on the 2-second rule. That is basically a crock. There's so many things that can change that number. Consider treatment for cardiogenic shock if you feel like the heart may be the problem, and then make your transport decision. So if anybody is going to be a high priority for transport for you that's medical, this would be it, right? If they have chest pain, even because we can't diagnose angina, we can't, as EMTs, we don't know the difference between, or I'm sorry, we do know the difference, but we don't have a way of detecting the difference between angina and actual heart attack. We can ask some questions and try some things to help differentiate the two, but it ultimately is going to end the same in your transport decision. They're going to be a high priority. They need to go to the doctor. And keep this in mind too. When you make this decision, you get them in the truck and you can do your assessment on the way. You can ask their sample history on the way if they're awake. If they're not awake, you can get a family member to ride with you to ask your questions, all that stuff. Get their vitals in the truck. Just do your primary on the scene. Make sure they're not going to die in front of you, and then get them in the truck and go. As a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner possible. We even teach that to just basic first aid. If if I'm talking to a caregiver for a grandparent or something, I'm gonna say, like, if they start talking about chest pain, they say their chest hurts, do everything you can to calm them. Lower the lights, talk softly, call 911, but don't do it around them because you don't want them to freak. Assure them, not false hope like assurance, but talk to them, try to keep them calm. Same thing. If you, as an EMT, Wesley, correct me if I'm wrong, but most not cardiac arrest, I keep saying that, most heart attack patients are going to be transported without lights and sirens, unless the paramedic tells you otherwise because dude's about to die on them. So, and the reason that we do that is because it's better to take a little bit longer to get there and keep the patient calm, keep their pulse down, than it is to, freak out, pedal to the floor, lights and sirens going, speeding through traffic, scare the shit out of your patient, and watch them go into cardiac arrest on you. History taking, you're always going to investigate the chief complaint. So whatever they tell you is hurting, unless you work for Pafford and everything is lights and sirens. Well, I didn't say that, you said it. So, because patients experience a myocardial infarction will have different signs and symptoms, seriously consider all complaints of chest pain or discomfort, shortness of breath, and dizziness to be a serious thing. And that's what I'm saying. Like, we don't have access to the monitor, not by ourselves. If you got a paramedic there to hook to mess with it, then great. But with what we have at our disposal as EMTs, it's pretty much just a better safe than sorry thing. Just treat it as being a critical thing and get them to the hospital. Because also keep in mind, like we already mentioned, different people register pain differently. So a female will tell you that they feel pain in a different way than a male will for the same issue. If the patient is experiencing dyspnea, which is difficulty breathing, you ask yourself a couple of questions. Is it due to the patient's position? So if they sit up, does it help? If they lay down, does it help? If not, then that points you more toward a heart attack. Heart attacks do not get better when the patient changes position. Is it continuous or does it change with deep breathing? If the patient has a cough, does it produce a sputum? Again, if they have congestive heart failure, they're going to be throwing up a bunch of stuff. So, and it's coming out of their lungs, not their stomach. So throw up is the wrong word. They're just going to have this looks like old milkshake coming out of them. That's coming out of their lungs. That is a sign of congestive heart failure, and that you really do need to be aggressive on, because they will drown in dry air if you don't do something about it. Does the patient have nausea and vomiting, fatigue, headache, or palpitations? And ask about recent past trauma. Surgeries count. Surgeries are big. In fact, a lot of times you may find that your heart patient, a lot of their issues are probably due to a complication with their recovery from a surgery, especially the older they get. All right, for your physical exam, a little bit more, and we'll take a break. Focus on the cardiac and respiratory systems. All right, so not just in your primary, but also in your secondary assessment, like it says here on the screen. Assess your pulse at various locations. If they feel different, that can kind of point you down the road of either an aneurysm, some actual heart issues will cause that. Like their skin color, their skin temperature and condition, that tells you about their perfusion. If their skin is starting to look weird, that means they're not getting blood everywhere it needs to go. It's starting to get kind of down the shock route where their blood is shunting to their midsection. Listen to their respirations. Are the lung sounds clear? You should hear clean movement of air. You shouldn't hear any rales. You shouldn't hear any fluid, that kind of thing. Are the neck veins distended? So we call that jugular vein distension, or JVD. If there's a problem with the heart that causes the blood to not be able to enter the heart like it should, and it starts to back up, you're going to see it in the jugular veins. They're going to start to distend out. That is one of the signs that they are having a blood flow problem. It could be cardiogenic shock. It could be congestive heart failure. It could be any of those things having to do with the heart itself. All right. Is the trachea deviated or midline? So again, we're still talking about their head to toe at this point. The three things that we check when we get to a person's neck is the front, sides, and back of everything, either trauma or not. The front, we're looking at the trachea. We want to make sure it's straight down the middle. If it's pushed off to one side, that means we have a problem with our lung. The sides, we're looking at the jugular veins. You can see people's jugular veins, but they should not be like massive pipelines sitting out on the side of their neck. That's usually a sign that the blood flow is getting backed up, and that's a problem. And then on the back, we're feeling for step offs, which is where like one spinal vertebrae is out of sync with the rest, is out of line. You really only find that in trauma. But again, if let's say you come across a patient that's already laying on the ground, you can't rule out trauma. That's one of the things we're going to look for. For your vital signs, get your pulse, your respirations, your blood pressure. Get your blood pressure in both arms, because again, if you're looking at an aneurysm or something of the sort, your blood pressure is going to be different. They should be the same or very, very close to it across both arms. If you get one that's like significantly different, that's an issue. If you can get pulse ox, most everybody can. We carry, even just a little battery operated, once it go on your finger, you can get. If continuous blood pressure monitoring is available, use that. We really don't have that as EMTs. We have our nice Walgreens stethoscope and blood pressure cuff. Repeat at appropriate intervals. So if they're unstable, which anybody with chest pain is going to be unstable. I don't care if you're in class or the real world or whatever, it's unstable. All right. Nobody's chest should be hurting without a reason. So every 5 minutes, you're going to be repeating your vitals. If a paramedic shows up and wants a 12 lead, it is in your scope, if you've been trained to do so, to place the leads for a 12 lead. You can't read and interpret it, but you can put those stickers where they need to go. You can do that. That's in your scope. Again, for your reassessment, reassess any vital signs, or I'm sorry, reassess your vital signs, but reassess any primary assessment things that you've done. Any interventions you had to do in the primary assessment, reassess that to make sure that you don't have to go back and do it again, because those are your life threats. Reassess your vital signs every 5 minutes. If I've got a patient that is at risk of going into cardiac arrest, I'm putting the pads on them. Whether or not I'm going to turn the AED on immediately is different, but I'm going to go ahead and have it set up. And if I did have a cardiac arrest, I get somebody back. the pads are staying on them, because if they've gone into it once, they're very high risk to go into it again. All right, we're gonna take a break here. I think it's 8 o'clock. So take another 10 minute. We'll be back at 10 after, and we will continue on. We're getting pretty close to the home stretch here. Hey guys, give me a couple more minutes. Working on something that popped up during the break, and I will be back as soon as possible. I would say 5, but I don't even think it'll take that long. Okay, sorry about that. Trying to juggle a few things. So, there's a good bit left of this chapter, but the good news is that a lot of it is skill based and a lot of it is actually just CPR all over again. So we're not going to do everything. In fact, once we get to the CPR portion, I'm pretty much just going to stop there because that's the last part. And we did CPR just the other night. So it's really, I was looking through. There's no new information, uh, other than like some team management type stuff. And we're going to do that stuff will happen at the boot camp. So there's really no need in going over it here in the class. So what we are going to talk about now is the emergency care that we are going to do for chest pain and discomfort. So the first thing we want to do is make your patient feel comfortable, right? The more uncomfortable they are, the more their pulse is going to spike. It's the same thing as if we're running lights and sirens down the road, like we were saying. So let them sit how they want to sit. Sometimes that may be reclining. If they're having trouble breathing, then they're going to try to get into the tripod position, but that's you let them choose. Most of the time, if there's no respiratory issues, as far as your stretcher is concerned, a lot of times what we'll do is we'll set the back at like a 45-degree angle so that they can kind of recline back and relax. As long as they're not having a hard time breathing, that will be a comfortable position for them. Just know that if they're struggling with like CHF, for example, they're going to fight you on that. You're going to want to set them up, you let them sit forward, that kind of thing, because it's a different issue at that point. Loose and tight clothing, give oxygen as needed. Continually reassess your oxygen sat and patient's respiratory status. Treat the patient, not the monitor, is something that we say all the time. Your numbers may look good, but your patient is looking like crap. Um, so treat the patient. Use a nasal cannula for patients with mild dyspnea. Again, we don't want to just overflow them with oxygen unless they absolutely need it. Keep that 94 to 98.9% range. Um, However you need to. If you got to go up to a non-rebreather, then so be it. That's fine. All right. Depending on your local protocol, prepare to administer low dose aspirin and assist with prescribed nitro. So here's one of those times where I'm going to tell you again, I want you, when you come up to a patient, I want you to be determining your care to take care of the patient. I don't want you to do the assessment just for the hell of doing the assessment. That's not the point of it. The point of it is to try to fix your patient or stabilize them, make them feel better, that kind of thing while you get them to the hospital. So there's an acronym that we use, and we call it, it's either MONA or FONA. All right, MONA or FONA. It's up to you. It really doesn't matter for you as an EMT because the difference in that first letter is either morphine or fentanyl, and that's going to be the paramedic. The other three letters, though, are absolutely within your range to do. So if you go to any patient that's got a cardiac problem, this is the first acronym I want you to think about. All right, is that ONA. O is oxygen. If they're having chest pain, they're going to get oxygen. All right, again, like I said in the last slide, we're going to titrate that, not a big deal. N is nitroglycerin. So we're going to consider giving them nitro. That doesn't mean just throw it in their mouth or anything like that. We do have to make sure they can take it. All right, and we're going to talk about nitro in the next couple of slides. A is aspirin. So those are your three as an EMT. Those are three things you can give your patient, unless your protocols tell you something different, that will absolutely make your patient feel better, or at least be something you can do for your patient to help improve their outcome. That's the point of it all, isn't it? I mean, I know that in EMT school, and this is what I hated about my EMT school, is they just beat us to death with the assessment for the entire class. And then when we came out, we were really, really good at the assessment, but we had no clue what to do for the patient. All right, that's not what I want y'all to focus on. So your patient care comes first. Your assessment is just a tool to make sure that you can do the interventions that you want to do. For example, when we get to nitro, there's going to be a lot of things that can contraindicate nitro, and your assessment is how you're going to figure those out. But since the slide went to aspirin first, we're going to talk about that one. There's really no side effect, or I'm sorry, not side effect. There's really no contraindication for aspirin other than hypersensitivity, which means that aspirin just has a bad effect on them. Now there are some side effects. All right, if somebody is on blood thinners, it can work synergistically with that, where they have that much harder of a time to stop bleeding. Too much aspirin can start to damage the liver. All right, y'all remember back when Bayer aspirin got a bad name for a long time because they found out that it was hurting people's livers. But for the most part, if somebody's in a cardiac issue, you can get them to pop some aspirin. That's okay. Nothing wrong with that. Now, the amount that they get is either going to be 324 milligrams or 325 milligrams. It depends on how you're giving it. Baby aspirin is 81 milligrams per tablet. Now, the thing about that is that it's not baby aspirin as in it's pediatric. In fact, we don't give aspirin to peds. It's baby aspirin in the fact that it's just a smaller pill. So 4 of those makes 324 milligrams. Or if for whatever reason your medical bag has adult aspirin, the adult dose is 325 milligrams and it's 1 pill. So that's why your number might be 1 off or whatever. But if most people carry the smaller ones, they're 81 milligrams. So you give them 4, it comes up to 324 milligrams. Have them chew it up. Don't let them swallow it whole like they normally do. The reason being is because there's that protective coating on it, and we want it to get into their system faster. If they swallow the pill whole, the protective coating around the aspirin makes it take longer to take effect. So have them chew it. All right. Once they chew up that film on the outside, the aspirin gets into their bloodstream a little bit faster. Not to mention, some of it's going to get stuck in their teeth, which may eventually fall around their cheeks and under their tongue and stuff like that, and then it's going to get put into the bloodstream faster. So again, faster dose. All right, so your nitro. We give this in a couple different forms. There's a sublingual pill, sublingual spray, a skin patch applied to the chest are the main ways to do it. Not a lot of systems like the skin patch or the paste because you have a high risk of getting it on you, and now you're having problems too. So the mechanism of action, this is what it does. All right, this relaxes your blood vessel walls as a smooth muscle relaxer. It increases blood flow and oxygen supply to the heart because it dilates those arteries and veins around the heart. Now, the goal is to dilate both your coronary artery and your aorta, your other arteries, so that the workload on the heart is a little bit less, right? So that third line right there, that decreases workload on the heart. Wouldn't the transdermal patch be too slow to be effective anyhow? Probably. I've never actually encountered the transdermal patch, but I assume that it would take a long time, kind of like swallowing a pill. Um, a lot of that's assumption, just because I've never used the transdermal patch, nor have I encountered it. We've always had either the pill, the spray, or if your agency is feeling brave, the paste. Um, this does dilate the blood vessels. Now, here's the thing: your heart has two. There's two loads of pressure that we talk about when we talk about the heart. You have your preload. That is the pressure that is in the vena cava, is waiting to get into the heart whenever the heart um, relaxes to allow blood to go in. And then we have the afterload, which is the amount of pressure that the heart has to push against to get blood into the aorta. When you have to have a certain amount of preload to get blood into the heart. The heart doesn't suck blood out of the vena cava. It's got to be pushed into the heart. So if we give nitro and their blood pressure is too low, and we dilate those vessels too much, or which is going to lower the blood pressure even more, or if they have right-sided heart failure, which is on the vena cava side, and we give nitro, we run the risk of crashing our patients. So as EMTs, we really can't detect right-sided heart failure. That's a 12 lead, and it's going to be the paramedics knowing when to, based on what they see under normal conditions, they're going to have to move some leads to the other side and take a look to get definitive proof and all that. Is way out of an EMT scope. So I want you to know that that exists as a problem, but there's nothing we can actually detect that with as an EMT. So outside of just knowing that that's a possibility of an issue, that's as far as you need to go with it at this level. But the blood pressure absolutely is within your scope to check. So keep that in mind. If you decide that you want to help a patient take nitro, let's see, here we go. It may sound like a dumb question, but will you teach how to take a blood pressure in boot camp? I see so many who can't. Yes. Yeah, that's a skill. We're going to be going over that. In fact, that'll be day one. We're going to go over all the vitals, how to take them. We're going to do your individual skills, like how to use the BVM, how to hook up the oxygen. We will start with the small stuff like that, and then we're going to progress into the scenarios where you're just running calls and you're plugging all that stuff in. So the things that we give nitro for is basically chest pain. Um, and think about this too. If it's cardiac or not cardiac, I'm sorry, congestive heart failure patient, and they have the fluid in the lungs because there's no room for it in the vessels in that area. What are we trying to do, right? We give them positive pressure ventilation through the CPAP or BVM to push that fluid back out of the lungs, right? But here's the thing: where is it going to go? One of the things that you can do for congestive heart failure, aside from giving those breaths, is if your patient has nitros, obviously same as any other time, clear it with your med director, but they're going to want you to do that as long as the blood pressure checks out and so on and so on. Give them a nitro. It dilates the blood vessels. It gives that fluid somewhere to go when you push it out of the lungs. And if it's got somewhere to go, if it can sit into the vessels without being immediately shoved back into the lungs, you're not having to sit there and keep fighting that war the whole time you're dealing with your CHF patient. Some side effects of nitro, severe headache. That's just part of it, right? That vasodilation that you're giving is going to cause them to have a headache. It may cause a change in the patient's pulse rate. So they could either get faster or slower. It depends on what their pulse was prior to you giving it. Usually the pulse rate will pick up because when you dilate the blood vessels, the blood pressure is going to drop, and that's what the pulse rate serves to fix. The pulse rate is there to maintain the blood pressure. So when the pressure drops, the pulse is going to pick up to try to keep the blood pressure where it needs to be. Contraindications, and this is why your assessment matters. After administering nitro, if the patient's systolic blood pressure is less than 100, do not administer more. If they are already less than 100, you're not even going to give the first one. They have to have a 3-digit systolic to get a nitro. And to be honest with you, I don't know very many paramedics who are going to give nitro if they're hanging out around 100. So they need to be a good systolic blood pressure. Head injury, if they have the risk of having some bleeding in the head, we don't want to give nitros, because if we open up the blood vessels, we allow more blood up there, and then that's just that much more blood that's going to leak into the brain cavity. If they've used erectile dysfunction drugs within the last 24 hours, and I will say within the last 48, because a lot of them are time release now, they work very synergistically with nitros. They will crash a blood pressure. They may be sitting at 120, 130, somewhere around in there, well above the 100 threshold. You give them a nitro and they crash. So it's important that you get that history. That's a very specific question you have to ask them, and treat him like the 15-year-old teenage girl that you want to know if she's sexually active. Get him by himself or whatever, because he's probably going to lie to you and say, no, I don't need that stuff. Tell him, be like, all right, well, look, I got to give you this med, and if you've taken it in the last 24 to 48 hours, even if you didn't need it, if it's in your system, this could kill you. And I really don't want to be breaking your ribs today. Get them to be honest with you. If you have to get them alone, that's fine. And then your maximum prescribed dose, if it's already been reached, which is usually 3 doses, it just depends on the amount for each dose. The spray, sometimes we'll go over 3 doses. I've seen paramedics spray nitro spray down somebody's throat like they were trying to give them fresh breath. It depends. And that's on them. But yeah, anytime you give, especially like a pill, a lot of times it's going to be up to 3. And your med director, when you call them to get the permission to give it, is going to tell you, up to 3 doses. Or they may, even if they're not overly swamped, they may tell you to call them back after each one. It just depends on your med director. So if you go to give nitro, make sure the medications are neither expired nor contaminated. It should be clear. If you're looking at a fluid, if the pill looks dirty, that kind of thing. Wear your gloves, especially if you're dealing with nitro that you can absorb through the skin. And ensure the medication is prescribed for the patient. A lot of us keep nitro in our bags as paramedics and everything, but if we walk into somebody's house and it's either our nitro or their nitro, they're getting their nitro. So just because it's already prescribed to them, we know it's their dose, all that stuff. All right, cardiac monitoring. I was actually looking at this during the break. None of this all this is how to attach the leads. So because this is a skill and we're not going into how to read it or any of that, I'm not going to bother with it. We'll do that at the boot camp. And then we're going to go into heart surgeries and cardiac assisted devices, and I believe that is going to be it for the night. So over the last 30 years, hundreds of thousands of open heart operations have been performed to bypass damaged segments of coronary arteries in the heart. I remember being a kid and my grandfather having to get a double bypass surgery. He was in his 40s, so that doesn't bode well for my future. But and my dad having congestive heart failure, I'm really behind the curve on that genetic. But we're getting better and better at it. And we've actually got not just bypass surgeries, but we also have a lot of cool electronic toys that can make things better too. And we're going to get into that here in a second. In a coronary artery bypass, a blood vessel from the chest or the leg is sewn directly from an aorta or from the aorta to a coronary artery beyond the point of obstruction. So basically, if there's a blocked off artery, be it from atherosclerosis or a thrombus or something, they'll take a piece of your vasculature from somewhere else in the body, and they will basically create an emergency lane to go around that blockage. All right. Let's see, percutaneous. All right, so percutaneous transluminal coronary angioplasty, which is definitely a mouthful, involves the following steps. This is where they basically go in with a tiny balloon inside the artery, and they inflate the balloon, which opens up that artery. So if it's a partial blockage, um, they can actually get in there with these little tiny balloons and inflate it. And then sometimes they'll put in like a stent or something like that that keeps it open so you can get good blood flow without having to sacrifice arteries from somewhere else in your body. Um, Patients who have had a bypass procedure may or may not have a long scar on the chest. It depends on how they go in. Not everything is, rip the chest open anymore. Now they've gotten a lot of this stuff down to where they may go in through the femoral artery. Like they'll make an incision in your leg, go into the femoral, and then go all the way up through the aorta to get to where they're going to work. Or they may go in through the brachial artery or something like that. Much less invasive. Those patients sometimes will go home same day because they didn't get this massive cut, where they ripped open the chest. Treat chest pain in a patient who has had any of these procedures in the same way you would treat chest pain in a patient who has not had a heart surgery. Some patients have pacemakers. We learn about pacemakers in CPR, but we're going to talk about them a little bit more in depth here because CPR is pretty much, if they have one, do this. Let's see. Doing a lot of robotic heart surgery now and looks like an endoscopic puncture. Is that for you or people you're working with? You don't have to answer that, by the way. Okay. Working with okay, I got you. Yeah. Yeah, it's some pretty cool stuff that they're able to do now. All right, so for pacemakers, your pacemaker is helping with the electrical side of the heart. I want to make that clear because when we talk about LVADs here in a second, they're on the other side of the fence. Um, a pacemaker is designed if your SA node is sick and it's not able to keep up the 60 to 100, you can get a pacemaker. If there's a block, you can get a pacemaker. We didn't really go over blocks because they're a little out of your scope, but I do recommend for further reading, look into that stuff. You're going to run into it in the field. If you're easily confused by things, or not easily confused, but if it's easy for you to lose track of where your scope is, for example, because like let's say you go out and learn about blocks, now you're a master of heart blocks, but heart blocks are out of your EMT scope. Maybe wait until after the registry. That way you're not getting those questions wrong, where the registry might be testing your scope of practice knowledge kind of thing. But um, if you can keep your scope separate and remember where that line's at for an EMT versus an advanced provider, um, then by all means go ahead and learn. I love heart blocks. I geek out to cardiology like crazy. Like this is I'm not gonna say a drug, but I love it. So anyway, pacemakers are internal, and they basically pick up where the electrical system of the heart is messing up. They deliver the electrical impulse through wires that are in direct contact with the heart, and they can be either popping on the atrial side or the ventricular side or both. And they can also be either like on demand, which is where they just sit back and watch the heart. And when the heart messes up, then they pop it. Or they may be static, where there's like, you know what, this block is not going to work. The system that they put in there is designed to, it will make the heart, it'll provide every single heartbeat. The only thing about pacemakers, especially if you're using those kind, there's no way to adjust your pulse. All right, those pacemakers aren't able to detect when you need more oxygen. So if somebody's on a pacemaker like that, they're not going to be able to go out and run a race or do anything that's going to raise their blood pressure or raise their pulse rate, because those pacemakers aren't going to know how to do that. So they're pretty much going to be sitting on the recliner watching Jeopardy. You don't have to be concerned with the problems that can go wrong with a pacemaker. Just know that sometimes they do. Now, if for whatever reason you have to go to the hospital for somebody with a pacemaker issue, if they have anything external, let's say it's an old pacemaker, or if there's any other equipment that goes with it, bring that with them. If you're using an AED, that obviously means the pacemaker is not working. However, you want to make sure that you don't put the pad directly on where the pacemaker is at. So If they're using one of those pacemakers that you can still see the bump, like the bump in the chest, just move the pad somewhere to the side of it. Newer pacemakers are getting smaller and smaller. It's getting to a point now where you can't see that lump anymore, which is both good and bad. It's good for the patient because they don't have to feel weird about having this deck of card sized lump on their chest, but sucks for you as an EMT because you're very likely to put the pad there and then blow the pacemaker up when you shock your patient. All right, so we just talked about that. It's just more about the pacemakers. Automatic implantable cardiac defibrillator is basically an AED, but is inside the body. They do the same thing. If somebody has a bad habit of falling into a shockable rhythm, which is, what are the shockable rhythms? There's two of them. Okay. Yeah, your autocorrect got you. So VFib or VTAC. Good job. Um, if your patient has a bad habit of falling into those heart rhythms, then an internal defibrillator will be put in. That way they don't have to carry an AED around with them or anything. And it just watches. Every time it sees that rhythm come up, it pops them. So those are tragically comedic sometimes because um, you could be sitting there. I say it's not really funny, but like your patient will be talking to you and then they'll just kind of jolt because they got hit by their AED. It's usually a much small amount of electricity, not like an AED because it's right there by the heart and it's connected directly to it. It's only a fraction. Um, but it does. You'll see a little tremor, like a little pop from the patient. But you as an EMT, you don't have to worry. It's not enough to shock you. The shock is only going. It's only enough to get to the heart. It diffuses out before it makes it to you. Um, Treat them like anybody else. Again, if they're having a heart problem and they go out, do the same thing, right? Put the AED pads on them, let it analyze, because it could be that the tech is failing. That happens, right? The battery's dying, something like that. External defibrillator vests. Patients that have not gotten an internal defib will sometimes wear these while they're waiting on their turn for surgery for it. Um, this is a device that basically they just wear it. It's like an AED. It's still attached. It's still watching their heart. It's still going to shock them when it needs to, but they wear it. It's not an internal thing. The leads are internal, but the device itself is just the vest. Um, the vest is attached to a monitor worn on a belt or hung from a shoulder strap, so it may look like they're carrying a purse, or they may have something strapped around their waist. This device uses a high energy shock like an AED, so yes, be very careful. If they're wearing something like this, you don't want to do too much touching because if it pops them while your hands are on the vest, it might get you too. So just be careful about that. If if it's necessary to remove the vest, just simply take the batteries out. Um, that way, if the batteries aren't there, it can't deliver a shock. There's nothing for it to power up from, and then you can remove the vest like anything else. All right, LVADs. So this is the last thing that we're going to talk about tonight, and this is basically the pacemaker for the hydraulic side of the heart, where the pacemaker is trying to make up for the lack of an electrical or an adequate electrical function. The LVAD is making up for an inadequate hydraulic function, which means that the blood flow is being controlled by this. These devices are pretty new. They're used to enhance the pumping of the left ventricle in patients with severe heart failure or anybody that's in need of a temporary boost due to a heart attack. So, we talk about left ventricular hypertrophy, which is where the heart muscle gets so big that it can't really give a good flow. There's not enough room to get a lot of blood in there. These LVADs will constantly flow the blood. They don't do it in a pulse way. They just flow the blood. Or if there's any other reason why the heart can't give a good amount of flow, if the output is not where it needs to be, these LVADs can help out with that. They may be they're usually continuous according to the lesson plan. Sometimes they are pulsatile now, which means that they do kind of feel a pulse, but I haven't encountered any of those. The ones I've encountered have been a continuous flow, which is interesting because your patient will be up talking to you and you won't feel a pulse, but they're getting blood flow because that LVAD is going. Um, if they do go unconscious again, it could be that the tech is failing. So do CPR. Don't worry about whether or not you push something out of the way. It doesn't mean anything if they die on you. So treat it like any other patient. The patient or the family are usually going to be the experts on this device, so you don't have to be. They're all, when they get it, they're trained. They have actual like LVAD technicians come in and teach them all the ins and outs about how to operate the menu, where the batteries go, all that stuff. Um, unless the device malfunctions, you shouldn't have to deal with it. Even if it does malfunction, again, you typically aren't going to have to be the tech that fixes it. That's not your job. You're not trained for that. Contact med control if you have any doubt about what to do. Usually they're going to say bring them in, and if you do bring them in, bring all the LVAD supplies with them. That includes the battery packs and all that stuff. Because think about it like your phone, right? If they go to the ER, anybody ever go in and out of the ER in 5 minutes or an hour? Usually you're sitting in there like 6 hours, 7 hours, all day, overnight, all that kind of stuff. You only got so many plugins in the ER. So even if the battery is not dead when you take them to the hospital, they could die on them while they're there, and you don't want the patient to be sitting there with a dying LVAD and their battery packs and everything being at the house. So keep that in mind. My head injury a few weeks ago moved me out of there like I had the Rona. Yeah, but they probably put you in a different part of the hospital, huh? They didn't just like kick you out the door. Out the door. Wow, that's an interesting. All right, I stand corrected. I guess. Remind me not to ever go to that hospital. All right. That is it. The next thing up is cardiac arrest, and again, we just did cardiac arrest the other night, so there's really nothing new in this chapter. So we're not gonna deal with it. We are gonna go over this stuff at the boot camp. That's just because it's skills based. We will go over placing leads. Again, I'm gonna teach you guys. I'm gonna teach you all where to put the leads, but don't mistake that with having to read the monitor. You're not gonna have to actually work the monitor. It's just that they're teaching this to EMTs now to help the paramedic out. Because otherwise, you're just going to sit in there looking around like, what do I do? This is something that you can be doing while the paramedic's got a whole list of ALS things that he's got to take care of as well. So that's it for the night. Any questions on what we've covered? I know it was fast moving. It's one of the perks of us recording this is because you can always go back and watch it again. And I will be pulling up your pen real quick. No questions? All right. So your pen for the night is going to be B as in Bravo, C as in Charlie, 1-6, C as in cardiac. If anybody can type that for me, since I don't have the ability to type into the group apparently. B's. Yep, that's it. Thank you. So Bravo, Charlie, 1-6, Charlie. All right, guys. It is Thursday night, so a couple nights before we have class again. If you have any questions, if anything comes up, let me know. When is this module? This module is going to take a while. Module 3 is the biggest module in the class, so you guys are going to be in it for a bit. Actually, that's a good point. Because we don't require you to do your chapter tests when they're due, I will say this: if there's ever a module that you need to not wait to the last minute to do your chapter tests, this is it. Because there are so many chapters that make up this module. If you wait to the end, you're going to spend all day trying to do your module tests, or I'm sorry, your chapter test before you even get to the module. So no, you don't have to do them on the day that they're listed, but really don't fall behind on that. All right. Try it. If you're more than a week out from a test from where it's scheduled, try to catch up because there's a this is a massive, massive module. There's a lot of information in it. So go ahead and module or wait a chapter of 2 or more. What do you mean, Corey? Well, we're talking about module 3. Module 2 is due. Module 2, I haven't gone back and looked to see if anybody's behind on that, but definitely finish up module 2 if you're still in that range. Um, module 3, I would say you don't, I mean, the same thing. If you look at your schedule that we put out, the PDF, which if you don't have it, it's in the files in Canvas, but it'll show you when the module itself is due, module 3. The only thing I'm saying is don't wait till the end to do your chapter tests because there's so many chapters in this module, it will take you forever to catch up if you try to do them all at once. Like it'll be all day, probably 2 days, that kind of thing. But this is the bulk of it. After this, we have trauma and special populations, and then that's it. It'll be boot camp. So this is the hard part. Trauma's easy. You can see trauma. This will be the part where we're really trying not to overload y'all. But that's all I got. If y'all have any questions, hit me up. Otherwise, I'll see you on Tuesday.